Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be the facilitator for today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email in the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Bevel Texas providers, please make sure that you identify yourselves during this session, or if you're joining via phone, please email your phone number and email to beveltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or our discussions. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right corner of the Zoom screen to find this menu. If you're having trouble accessing this feature, please chat Echo IT. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. This helps us get valuable feedback about how we can improve these sessions. Our didactic today is on hospital standards of care for SUD treatments presented by Dr. Chris Moriates. Following that, we will be discussing a case presented by Lindsay Kosin. We will start with introductions followed by didactics, Bevel programming, announcements, the case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach, all learn, we encourage you all to share your questions, experiences, and insights in today's conversation. With that, we'll do some introductions. Dr. Moriates.
Hey everybody, Chris Moriates, hospitalist, assistant for healthcare value at Dell Med School, and part of the Shout Texas team.
Thank you so much. Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm one of the hospitalists over at Dell Medical Center, also part of the Shout team.
Thank you. Dr. Walker.
Hi, Blair Walker. I'm with psychiatry at Dell Medical School and Ascension Hospitals and Dell Seton Medical Center.
Thank you so much. Dr. Lindsay.
Hi everyone, Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring at Bewell, Texas. Thanks.
Thank you. Alana.
Hi there, everyone. I'm Alana Bolton, the Director of Shout Texas at Dell Medical School. Thanks so much for being here today.
Thank you. Lindsay.
Me, huh? Hi, everyone. I'm Lindsay Kosin. I'm a peer specialist at Recovery ATX.
Thank you so much for joining us. And we have two special guests today who are subject matter experts. Phil, if you would introduce yourself, please.
Sure. I'm Phil Owen at Communities for Recovery. I am the Recovery Services Program Manager and one of the training facilitators at Communities for Recovery.
Thank you so much for joining us. And Rachel.
Hi, everyone. I'm Rachel Holloman. I'm a substance use navigator and educator, but my background is in social work, and I work at Dell Medical Center.
Thank you so much. Thank you, everybody, for joining us today. And with that, we will get started with our didactics. Dr. Moriates, whenever you're ready, please take it away.
Great, thank you. So I'm just sharing my screen, and also someone at the door. My dog is going crazy. I'm calling him from home. Anyways, all right, we will see how this goes. Angie, come here. Hey everybody, thank you. And we are going to indeed be interactive today, both during the didactics and during the case, because we're going to really we've got a great case and conversation to draw on all of our shared expertise and have an interprofessional conversation. So as mentioned, I'm Chris Moriates from Dell Med School. I'm from the Shout Texas team, and I'm going to be discussing hospital standards of care for substance use disorder treatment. And I will go through this this case in this article, and then what I want from you all is to help me reflect on how we apply this. So do not have any relevant financial relationships, and you can see the entire planning committee here disclosures. This is going to be a little different in that what I'm hoping to do actually is review a single recent article from the New England Journal, which we'll share, Hospital Standards of Care for People with Substance Use Disorder. And then as part of that article, discuss the policy changes that support adoption of evidence-based substance use disorder care in US hospitals. So we'll review the policies that these authors recommend. And then together, I hope we can reflect on how these lessons can be directly applied with their own clinical settings. The article that we're going to be discussing today is this one, Hospital Standards of Care for People with Substance Use Disorder, in the New England Journal this past summer. In case you missed it, highly relevant to all of us here. Written by Honora Englander, who's clearly a national expert in this space, and has actually helped kind of inspire many of the models around hospital care for patients with substance use disorder, as well as lead much of the research and work around this. And so they set up the problem in much the way I'm going to kind of, like I said, walk us through this article first. And so as we all know, they set up the fact that SUD related hospitalizations, readmissions, and healthcare costs are increasing, and that they're associated with high mortality from drug related and other causes. We all, of course, know this to be the case. They point out that one study of hospitalized adults with OUD in Oregon, 7.8% of patients died within 1 year. I've never had this problem with me. Hey, cut it out. It's okay. I do this all the time. I work here every day. It's never been an issue. Anyway, sorry. 7.8% of patients died within 1 year after discharge. And they actually use the analogy to acute MI. And they use this analogy throughout the article, which I think is quite powerful, as we'll discuss. And I think it can be something that we can draw on when we're advocating, because our hospitals, the public, most people understand having a heart attack, and that you need hospital care for having a heart attack. So I think it was quite a useful way that they framed this discussion by comparing it to having a heart attack in the hospital. So 7.8% of patients died within 1 year after discharge, similar to those who have an acute heart attack. They also go on to point that 1 in 9 hospitalized adults have a substance use disorder, and that most, as we know, are not receiving addiction treatment at time of admission. We've discussed, they don't use this term in their article, but as you know, we've all discussed that this is a reachable moment, that when people are hospitalized, we have an opportunity to reach them because they are taken out of their environment. Oftentimes they are contemplating some of the consequences of their drug use. And so we have an opportunity, and many of these patients, as we all know, are not patients that were seeking care or being reached by care elsewhere. So hospitalization is really a way to get to folks at a time and in a place that we perhaps could reach them in ways that we cannot otherwise. We also know, and there's a growing peer-reviewed evidence base to show that hospital-based addiction care, which to be clear means for patients who are hospitalized, usually for other acute issues, who receive addiction care during that hospitalization, it increases their trust in physicians, it increases their engagement in post-discharge SUD treatment, and it decreases SUD severity, stigma, and mortality. It also has this halo or ripple effect that's really been started to be measured and shown in studies, that it increases the likelihood that other hospital care will be trauma informed and will meet comprehensive healthcare needs of people with serious illness and SUD. So it actually improves other healthcare and healthcare outcomes by providing addiction care. And once again, we've certainly seen this with our B team and Shout Texas programs, and can share lots of examples of it. And I'm sure you have seen this as well. And there's a clear evidence base to support it. So if you want to draw on that evidence base, this article from the New England Journal has a number of citations. They also point out that those of us who've started programs have done so. There's been programs popping up around the country, but most of them rely on essentially a charismatic or very dedicated or passionate leader, a physician, or in this case, physician assistant. And like, that's great. It's great when you've got somebody who's going to passionately lead this work. But you shouldn't need a Rich Botner to start a program. All right, give me a minute. I'll be 1 second. Sorry about that. All right, so you should not need a Rich Botner to start a program. But absent clear funding or financial incentives, most hospitals are not offering evidence-based addiction care. And so without that, I'm not, they say, really, how are we going to drive our hospitals to doing this? The ones that don't have someone like Rich. In addition to lacking appropriate inpatient care, many hospitals have no clinicians authorized to prescribe bupe at discharge. We've discussed this as well. So another huge barrier and gap failure within our system is the fact that we don't even have clinicians who can prescribe bupe. And so once again, they compare this, they say, look, this is the functional equivalent of nearly half of hospitals in our country lacking metoprolol, which is the most widely used beta blocker and evidence-based drug that improves mortality for patients having heart attacks, and then clinicians who can prescribe it at discharge. So it's like as if half of the hospitals in the country just said, oh no, we don't have doctors who can prescribe that medicine, even though it's clearly been shown to save lives. We recognize that that would be unacceptable. The other major issue is that our hospitals have punitive policies around drug use and people who use drugs. So we know that there are many policies within our hospitals to search patients' belongings when they're in the hospital, to administratively discharge them, and to have harsher, policies that are really kind of carceral in origin around these particular patients in ways that we do not actually set policies or treat other patients with other acute medical conditions. The funding for addiction consult services across the country so far have typically required demonstrating to hospital administration a financial return on investment. So far, most of these programs have been that we can avoid readmissions, we can shorten hospitalizations. I know that that was part of our argument when we started the B team. We went to the C-suite. We're like, look, guys, you'll get a return on investment here. Actually, we weren't even asking them for an investment, to be honest. So it's like free, but here are the outcomes that you're going to get. You're going to get decreased readmissions, decreased hospitalizations. And the authors of this article point out that any imperative that hospital-based SUD care be justified on these grounds is deeply flawed. This, I think, is really powerful. Because I actually advocate all the time for this. I say we need to make that argument in order to get people on board. And they're actually saying we should be really careful about making that argument because we're setting ourselves up with a deeply flawed premise that we're going and saying that providing addiction care has to actually return on investment. Whereas they point out cardiology consult services do not exist to save money. Nobody, when you open up a cardiology service, and they're saying like, okay, we're gonna have a cath lab or we're gonna treat patients after a heart attack, does anybody say, well, is that gonna return on our investment? It would just be inappropriate not to do it. And then you've got policies that provide incentives for cardiac care delivery. You've got sufficient reimbursement that further promotes nationwide adoption. You've got sustainability of cardiac best practices, and it just sets it up in a way that like, it would be unimaginable for anybody to say, we're not going to treat these patients with life-saving therapies because it doesn't decrease readmissions or something like that. And this is the part of the article where I don't know if you can see it, but I certainly saw it. This is where Honora like dropped the microphone. So total mic drop by Honora, where she's like, yeah, by the way, how come every time I present this, you ask me to save you money, but cardiology consult services don't save money? So here are the policy changes that they recommend. Now, many of these are outside of our direct control. And so I think it's good for us to know about and to think about how we can influence them. And this is where I'm going to welcome, after I go through this table, reflections about where we can provide our influence and control around this. So they break this up into a couple categories. The first is clinical guidance. They say, you know, we should have evidence-based clinical guidelines that promote acute withdrawal and pain management, as well as medications for opiate and alcohol use disorder initiation and treatment linkage. And they have here the organizations. So they say, you know, we should get professional societies and federal and state hospital associations like the AHA, the American Hospital Association, to pick up this cause. We should be advocating to them that they should be putting out evidence-based clinical guidelines. We should be advocating for and putting in place hospital policies, such as trauma-informed security and behavior policies that reduce discriminatory practices. And here they say we should be appealing to federal and state hospital associations and professional societies. Although this one, I will say, I think is within our direct influence and control. I don't think this has to be at the federal and state level. This can be at the local level. So I know members of our B team have had meetings with our, you know, hospital security, with our hospital leadership and policies, and trying to help shape our responses and policies around how we treat patients with substance use disorder. Formulary recommendations. All FDA approved medications for SUD should be in hospital formularies. Again, I think we take for granted. We've all just accepted the fact that a hospital will say, oh no, buprenorphine is not part of our formulary. And I think we have to reframe and say, well, why? It saves more lives than metoprolol. Actually, that would be not on aggregate, but in relative terms, it does. And so we should be able to ensure that that's part of all formularies. And here they talk about appealing to a national pharmacy organization. The next category is around financing, that we should advocate, and this is really at mostly the federal level at CMS and state Medicaid agencies. But as leaders in this space, we should be advocating for increased DRG payments for SUD, for demonstration projects that promote innovation. So funding interprofessional addiction teams to be able to show the benefit of these services. And so there are, in lots of different disease states, models like this, where you have a Medicaid demonstration project to demonstrate, to demonstrate your effect, and similarly with Medicaid demonstration waivers. Regulatory standards, they talk about we can advocate that hospitals adopt basic addiction care standards rooted in evidence as a safety standard. Once again, just drawing on looking at other disease states, this would be how we would think about it, is that you have it is standard of care to provide this therapy. And in order to be accredited, you would have to demonstrate adoption of and adherence to evidence-based clinical guidance. They also advocate that this should be part of publicly reported quality measures. And then lastly, so the last parts of this big table is to provide implementation support. So practice facilitation and technical assistance from existing addiction consult services to sites with emerging services. This is a lot of, once again, this can be done at the policy level and on the national level as the authors of this article propose, but really is what we're all about. This is what Shout Texas is trying to do. This is what we're trying to do together, is help say, here's our model, and help provide just-in-time practice facilitation and technical assistance to others to do that. There's the ability, I think, for us to provide more real-time clinician-to-clinician support, such as a warm line within our state. But many of us on these calls can serve as the local experts to just provide that warm line locally to our colleagues. And we've advocated for that in a number of these groups. And then they call out ECHO in the New England Journal, and this is great. So this is exactly what we're doing today, telementoring with ECHO models to support that knowledge, skills, and attitudes. And lastly, a real focus on workforce education. And so many of us need to do this, but on a policy level, it would be that CMS could say, and CMS could do this like tomorrow, they could say all residency slots that we pay for must have SUD training. They do stuff like that, but they haven't done that for SUD. Okay, so I walked you through that article. So in case you did not read it, or in case you did read it in August, but like me could use the reminder about all the arguments there. And I wanted to open it up just for a couple minutes before we move along to reflections, to things that maybe you find useful out of that article that we could apply today. I have a couple thoughts, but I'd love to hear from you about things that we could apply within our own realm of influence. or reflections that you have about, okay, I can't change CMS, but now I'm aware that, like, collectively as our voice, these are the type of things that we need to advocate for. So let me pause here and hope that somebody other than my dog is going to speak up.
Thank you so much, Dr. Moriates. It was a great presentation, and I will open up the floor for questions or comments.
Great, Chris. Fantastic talk. Thank you so much. This is a seminal article highlighting a huge need for the work that you guys are doing and that we're trying to do here in Texas. In short, I just want to make a quick comment that not only do the standards of practice, you need to continue to follow what the guidelines are recommending, but the funding needs to make sure that it's there. And I know this organization has done a great job with being able to supply Narcan kits free. And I'm at JPS in Fort Worth, and we've been able to implement the distribution of Narcan kits to anybody who wants one or needs one in all settings across our network: outpatient, inpatient, ER, behavioral health, and in a lot of that emphasis really has been a product of the educational efforts of this organization. And so thank you, and yeah, strong work, and keep it up.
Thank you, Destin. Thank you for that.
Hi, this is Dr. Halliburton. I'm listening in with Maddie from JPS. We used to work in a rural area, and actually, when I actually went to work there, they didn't know how to do alcohol withdrawal correctly. Actually, they did not know what the CWA was, and this was a 300-bed hospital, but it was 2 hours away from major metropolitan areas. And so one of the things I kind of, as you were talking about, it made me think of is, in the cities, we have a hard time getting resources here, but when you get out into the rural areas, and Texas has a lot of rural areas and a lot of people that have problems, 2 hours of driving is like living in Egypt sometimes, just from a financial standpoint. How this just made me think, and I think it leads to a whole different conversation, but how do we help get this education to more and more rural areas, and also some of the resources to more and more rural areas? Because it's one thing to have it in Austin or one of the big centers, but to have it in a really rural area where there may only be 2 AA groups, and that's all the addiction services you have, even though it's been mandated that MHMR has to have some. That's not always an easy resource to get. And so I wonder, from this, I think, if we're going to, because some residency spots are in very rural areas, and if we made it mandatory, I don't want there to be less access because they can't meet that requirement. So I wondered if anyone had thoughts on maybe how we could start reaching that kind of population, because I think, when we see some of the worst iatrogenic induced problems with addiction, it's not from the cities, it's in the rural areas.
Thank you. Thoughts from the group?
So my thoughts were that, one of the things that we have started doing a lot is peer support, right? And that has been proven to help, lower, people going back to hospitals and things like that. Sorry, a long morning. But, my organization provides peer support all over the state. We provided telephonic support, we provide, support over Zoom, things like that. And it's, completely free. There are a lot of organizations such as Communities for Recovery as well that offer these types of services that have the ability to reach those rural communities and outside of the box kind of ways. And especially because a lot of people, I think, not a lot, but some people feel like AA is exclusive. So, peer support is more like a holistic approach and more of like a, we support however they want their recovery to go. So including services like that, and even, bringing a peer into the emergency rooms, right, is, we have a lot of data on that now, saying it's very helpful.
Thank you for that. And I think maybe, we could keep talking about this, but I think we can continue the conversation, particularly through our case discussion today, which I want to make sure that we have plenty of time to get to and discuss. So I think maybe we can move it along. My quick closing thoughts on this. One, I think I telegraphed this. Hopefully, I feel as though using some of these analogies will be helpful as we advocate, both on local levels, but nationally. Like, I actually think just continuing to say, this is crazy. We would never do this for a patient with a heart attack. How can you do it with a patient with this medical condition where we've got clear treatments that work? And saying that this needs to be standard of care and this needs to be a service that every hospital has. And hopefully through that, we get some more understanding. And then I think also hopefully the article helps provide some reassurance that what we are doing is right by being here today, by 45 of us choosing to spend our lunch hour supporting and discussing with each other about how we can provide the best care for our patients. So thank you. And I think it's good that we can be aware of these policies moving forward. So I know that's short.
Chris,
And, yeah, go ahead.
Just one thing real quick, since you were talking about the numbers, I love the MI analogy. One thing that I found has resonated with our outpatient family medicine folks is the number needed to treat. They have the by the numbers thing, and the number needed to treat to retain somebody in buprenorphine treatment is 2. And if you make the analogy to, like, you know, the hip fractures and bisphosphonates and hypertension and all these things, you know, nothing else compares. Everything else is either 100 or 83 in order in terms of number needed to treat. And for bup, it's 2. And I think it really sells very well to that, you know, the family physician, outpatient practitioner population.
Yeah, absolutely. I mean, once again, like aspirin post MI, and people are like, well, that's obvious. That's the number needed to treat is, I don't even know, but many more than 2 to reach a benefit. And so it really is remarkable. There are a few things that we do with a number needed to treat at 2. So thank you for adding that, Dustin. All right, like I said, we're gonna have time to discuss in the, I think, the context of our case discussion, but let me go ahead and move us along. I think next we've got some programmatic announcements.
Yes, so thank you, Dr. Moriates, and Angela, if you could please bring the announcements. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Next slide, please. Be Well Texas Clinic offers high-quality treatment for addiction recovery at low, no-pay or self-pay insurance, so all patients are accepted regardless of their payment ability. Next slide. If you need technical assistance beyond what is offered in our echo sessions, please complete an online request form and we will be happy to assist you. You can find this form on our website, cstat.udisca.edu. Next slide. Please join us next month for our Shout Echo. We will be discussing management of opioid use disorders in birthing patients. And finally, we move on to our case presentation. Lindsay, you can take it away once Angela brings up the case. Thank you so much.
Hello, so again, my name's Lindsay. I'm actually supervisor at Recovery ATX. I wanted to start this by saying that part of what I do as a peer, right, is working with people, and we have the motto, nothing about us without us. So I actually went through this entire form with the person that I am doing the presentation on, and you'll see that in some of it is written from from my point of view were the questions, but most of it is written actually in her words and in her point of view. Just don't let that confuse you. The questions I'd like to address are the person is stable in their recovery right now, so they don't really need anything substance related. So as a recovery support peer specialist, you know, do I continue to work with them or do I refer them out? And then I often, you know, feel discouraged or like I'm out of options with her, not just this person, but, you know, a lot of people that I work with. And is it unethical to tell somebody, you know, hey, I don't know what to do from here. You know, maybe what do you think we should do? So we'll go into the situation. And like, again, this is told from her point of view. She says, a few years ago, I left my ex-husband because he was abusive, but he was awarded custody of our children because I was using substances. Once I was away from him, I was able to stop using, start getting my life back on track when I gave birth to another child who struggles with multiple disabilities and needs constant care. I've split custody of my older children, but their father moved them out of state and refuses to allow me to see them. He also has a habit of calling CPS on me every few months for no reason, even though I have passed hair follicle drug screens consistently. I've had a lawyer look over the case for a few years, but it seems like nothing's getting accomplished. Meanwhile, I'm struggling to take care of my youngest, who needs medical care full-time, but both of her nurses quit recently and then they're unable to find replacement due to a home health shortage, nursing shortage. Her father's not around and she's unable to attend regular daycare for liability reasons. So I'm unable to work, which has left me in considerable debt and unable to pay my lawyer to continue working on my CPS case. My car recently broke down and I went through the RSPS training and I have a bachelor's degree in social work. Due to all of this, I'm struggling with my mental health and have been really depressed and feeling worthless. Success to me would look like gainful employment, utilizing my degree and skill set enough to support myself and my family without having to depend on agency support, and earning enough, to support myself and my family. And finally, having my ex-husband be forced to uphold the terms of our child custody agreement. What can I do to work on myself and stay healthy when I'm unable to find a job, support my family, and unable to see my older children, and while my ex is harassing me constantly, making false allegations against me? So some options for addressing the situation. I've been working with the LMHA and the other local organizations trying to find financial assistance until I can find employment. I have Medicaid for my daughter, which is willing to pay for nursing if we could find a nurse. My lawyer informed me that I have a good harassment case against my ex-husband due to him constantly filing false allegations, and he would be happy to help me with that as soon as I can pay him. So obstacles that I've come across are I have had financial aid awarded to me, but it's now being withheld due to the agency's financial shortfalls. My vehicle can't be fixed until they get this TPMS part, which is on back order. So it's sitting in the shop where it's been for months now. Barriers to employment include needing to be available to take care of my child who's medically fragile. So I would need to be in a remote position with flexible hours, at least until I can find full-time nursing care for my daughter. And then we didn't have a plan at that time.
Thank you so much, Lindsay, for sharing this case. And I open up the floor for any questions.
This is a humbling to face the many challenges that many of our patients face, and to have it laid out like this. So thank you for bringing it forward. And I think we strive for these ECHO conversations and presentations to draw on the expertise of our interprofessional team and others to bring it together. And I feel like we've got a really unique and perfect opportunity to do that today. So I'm very much hoping that we can draw on the expertise of our peer support specialists that have joined us today, and our social workers, as well as our physicians and other clinicians. So yeah, let me just, with that encouragement, I hope some of you can hop in and we can start discussing the questions that Lindsay in this case raised.
Yeah, Phil Owen at Communities for Recovery. This is one I just want to recognize that as providers at any level, the weight that we sometimes absorb when someone has this level of intensity of need, and that there is a lot going on here, and it can seem somewhat defeating when many of those avenues are closed. I think for me as a peer support specialist, I think about this person, how much have they overcome to get where they're at? What are those successes that she has obviously persevered through so much already? And so for me, I think as peer support specialist, I'm looking to maybe try to recognize some of those successes, no matter how small they are, and incrementally applaud them so that we can self-motivate and cheerlead some of that, because obviously it sounds very overwhelming, like all these avenues have shut down. But I think clearly if we get to know our person and hear about those little successes, even the idea of just coming in and asking for help, even just the idea that somebody is being so open and willing to share so much stuff with you is a success. You know, that is harm reduction in and of itself, that conversation, I think. So I do definitely applaud that. I also don't want to minimize the severity or the intensity of need that this individual is going through. And it, to address the question of, is there anything to work on here, or they don't really have an issue with substances or alcohol, I would just say, I think this person, maybe we look at all the things that we can recover from. Some people recover from domestic violence. Some people recover from having been human trafficked, and all the varying components that come with that. And I think this person is in recovery. And though the conversation might not be about substances or alcohol, clearly there's a lot of recovery going on from relationships and domestic situations, and these healthcare issues with the child, the conservatorship issues in the legal realm, which none of which I have the expertise for. But what I do know is that we can overcome adversity a little bit at a time and applaud those successes. I just, it's a very, Lindsay, I applaud you in the work. And obviously you've created a healthy relationship with this person just to share everything that you've shared in this case today. And I just, for me, that's where it started, is that relationship. There is a relationship of value going on here. Just the idea that she's able to share all this with you, I see a lot of value in it personally.
Thank you for all that, Phil. And maybe I can ask you, and I see Slade. It's really good to see you, Slade. If either of you have thoughts or approach around how you determine when it's the right time to transition or disengage, whatever term, I don't know what term you all want to use, but say like, okay, this person's graduating from needing peer support services around substance use disorder. You know, how do you kind of think about that? And, you know, maybe in the context of this case, but maybe more general.
Yeah. Our philosophy is we never exit anybody until they ask to be exited.
There is no graduation unless, you know,
graduation is determined by themselves. Discharge is determined by themselves, unless there ends up being a grievance or ethical issue in which somebody would be better off handed it to services somewhere else. But as far as when peer support works specifically with people in their self-defined, self-directed recovery. And so in order to respect that and the value of that, we don't ever have a plan on exiting anyway. People might go into an inactive designation because we haven't been in contact in months, but they're always in services as long as they would like to be.
Thank you for that.
Yeah, we have the same policy. This person I've actually been working with for about a year and a half, less than that, but over a year. And while I am not an expert like with CPS and things like that, I have still been there and available to her to just support her during those types of calls and things like that, which is great. That she's, you know, she reaches out and says, hey, you know, I'd like you to be there. And I find that that's one of the things that I do with most people I work with, is kind of just be there, support them through doctor's appointments or, you know, anything they need.
Yeah, I would just like to add, you know, what Phil was saying, the win is in the rapport. I mean, as far as what we get to do, the win is building and keeping and nurturing the rapport with a peer. That may not be the win for them. There may not always be solution, you know, but being able to be present and available and still continuing to point on what they're looking for and come up with those options if there are options. More than anything, it's just being present. Sometimes solution doesn't come for 2 months, 6 months, a year, you know.
Thank you for that. I'm wondering if others, I don't know, Blair, maybe you've got thoughts on this, but I'd love to hear from anybody in the group because I know there's a lot of varied expertise around this. But the second question Lindsay posed us, I sometimes feel we're out of options and become discouraged. Should I share that with the participant, or is that unethical? What's your approach to when you're just feeling, I mean, when I hear this story, I feel discouraged, just, spending the 2 minutes hearing it, let alone really experiencing it and trying to help this person. So how do you address that when you just personally feel just overwhelmed or discouraged by the gravity of the situation?
I mean, in psychiatry, I think you always are trying to be deliberate in whatever you're communicating and at least aware of it. As far as being unethical, I don't think it's ever unethical to say what you're feeling. And I think we sometimes talk in psychiatry about like a holding space. So I think so she's got all of these obstacles and you're feeling that with her. And so I think it's okay to say, wow, I'm so overwhelmed for you. I'm hearing all of this and what you're up against. And I think it's okay to divulge that the mountain seems real high to climb. But I think while also balancing it with the small wins and the kind of just step by step, how can we break this up for you to kind of make it feel more manageable? Because gosh, when I look at this, it seems insurmountable. I think that's kind of how I would sort of look at it, but I think it makes sense to feel that way. And I think you're probably picking up on how she's feeling. And so I think sometimes sort of reflecting without like contributing to like completely lost hope, because there's always hope. And it's funny, when I read this case, I didn't know that you were kind of peer recovery in the moment. Just when I read the case, I think I just wasn't looking close, and I said, gosh, this lady really needs peer support. She's also, I think, also looking and bolstering the positives. I mean, she's a survivor, and there's a lot that is up against her, both systems wise and just her personal situation. But she's done a lot and is doing a lot. And how do you help just kind of support her and bolster that? So I think it's okay to divulge what you're feeling, and I think I would reflect it on, gosh, what are you feeling? How are you doing? I don't know. That's sort of my thought. I welcome other people's thoughts and opinions. These are hard. We have, I think, also, knowing afterwards it's okay to feel exhausted, and have like, ooh, like I need a break, because it's sad and hard and feels tragic in the moment. And I think we all naturally want to fix things. And it's okay. And I think it's a challenge to sit with someone and not be able to necessarily fix it. And how do we help you tolerate this while you move through it?
Absolutely. I agree. And I just was so, and also from a peer support perspective too, is that, I think I rely a lot on authenticity and transparency with that idea in mind of, maybe I don't share everything I'm thinking, but also it's okay to let somebody know that I don't have all the answers. And honestly, I've never met the peer that thought I had all the answers. Sometimes they look to us for answers, but we're not perfect. We don't have all of that. Our layers of lived experience, even though it's that life is our college, role that we play, it's we don't have all the same pieces of experience that every peer we work with does, and that's okay. And I think it's okay to be authentic and say, I don't have all the answers, but I'm willing to try to find them with you, and just to kind of be there and hold that space a bit. I think that's okay. And then I do also want to recognize that self-exhaustion that I can experience when things are so heavy, and that I have to look at my own self-care because secondary trauma, or I'm just emotionally exhausted, because it's a lot to go through, even though I'm not the one experiencing it firsthand. It does weigh on me heavily, because we all want to fix things for people, and it's just not always possible.
So, and we do, like, one of the things that I think really kind of helps build our relationship is when I do all the time. I just tell her, it's like, I don't know. We can figure it. I'm not sure, but we can figure it out, right? I think as as a physician, is that it's okay for a peer to do that, is that okay for a physician to do? Or is, if I go to my doctor and my doctor's like, I don't know, let's figure it out. It's would that make, I would think about it like how that would make me feel, right? So in different positions, I guess it seems like it's a little like, what makes me relatable to somebody, is that something that would make a doctor relatable?
I can say this, working in a hospital setting, that there gets to be this transference of trust between the participant, the peer, and definitely any kind of staff that is available and interested in helping create a treatment plan. But, we get to help be that person who speaks that language and comes in, and you may meet them once for 10 minutes, but you never know what happens in that 10 minutes. I mean, you never know what shift or change gets to happen. You may be met with some of the most barriers and challenges and things that you just can't get past. But in that moment, you connected and built rapport, and they may decide to open up to you and the circle of care that's around them at the hospital. I mean, I know we've seen that, Blair, and I wish that there was more peer support in all the hospitals continuing on. I miss getting to be available for that often. But there's going to be more challenging cases. But Lindsay, I can say I can just see so much peerness in the case that you presented today, and I appreciate it.
Thank you.
I just wonder if anybody has any solutions for her immediate requirements in terms of like free legal services or something that she can access. So, so that she can move along those small wins, right?
Yeah, so legal aid.
I was going to drop the
reading that-
link. Sorry.
Yeah, awesome. Maybe Slade has it. Legal aid. I mean, the nice thing is too, anything that, like, theoretically she can't pay that lawyer. I think that he can release his record. Like, he can potentially give what the work he's done, if he's done any, to legal aid if she retains them instead, potentially. I don't know.
Yeah, unfortunately, we've been through the legal aid, the Texas Fairground legal aid, and there's one in Houston, actually, that she's in Houston based. With her case being out of state as well, it complicates things.
It's Colorado.
Hmm?
Her kids are in Colorado. Did I read that? Did I make that up?
Jesus, I can't believe I don't know where they are now. It just slipped my mind. They're out of state though. I think they're in New Mexico, if I remember correctly. But I know it's like an out of state case that kind of complicates things.
Well, I mean, in that case, I won't put the link, but I mean, any legal aid services in the other states, maybe making that call with her and having those conversations as well.
Any of our social workers on the call have other suggestions or resources to help her in this specific situation?
So she's also on the waiting list for the Medicaid, like a family program, right, that would help support her daughter who's medically fragile. But she's been on that waiting list for like 5 years, and it's not a very fast moving list apparently for the in-home care for her daughter.
Yeah, that's such a tough one with the home care, because I know during COVID, a lot of the home health, and COVID's not ending now, it's here to stay really. And a lot of the home health agencies lost a ton of staff, not just due to having COVID, but they couldn't afford to pay them. And I know the Medicaid rates don't pay very well for care anyway. So sometimes even if there is staff available, they don't want to accept new clients. So I was thinking of agencies like Any Baby Can or I don't know, it's a tough one.
We got a room full of people. All this is a tough one. It's hard to come up with solutions, but I think hopefully you're hearing. I'm hearing quite a bit of support for what you've already been able to do, and I love this this statement by Slade in the chat. We support. We are not helpers. That's a really nice framing for the role.
It sometimes feels so empty to say something like that, but it's the truth. And in the end, you know, getting to support somebody and helping themselves with what solutions are available doesn't mean in the moment. It doesn't always mean it's going to happen right then and there, as we all know.
What about her other family? Like, does she have like siblings or anybody who can help with the childcare for a certain amount of time?
Unfortunately, no. She you know, her ex-husband was very narcissistic. So that very often moved to the families, right? When she left him, her family pretty much deserted her.
Thank you. I'll draw our Bobby Sessions has a nice comment here in the chat about instilling hope, being gentle with ourselves when we can't fix it. System's complicated.
And I will say that most of the time we focus on a lot of self-care for her. You know, what can we do? I know she's always has her daughter, but you know, even 5 minutes or 10 minutes in a bath, just, you know, to breathe can be helpful, you know, after her daughter goes to sleep, and other ways of, you know, help her manage kind of a lot of the stress with the self-care is very important. Along with obviously resources.
Well, any other thoughts from the group? I think so, Lindsay, for your specific questions that you asked, this person stable in their recovery, does not need anything substance related addressed as an RSPS. Should I continue to work with them or refer them out? I feel like we heard quite a bit about that. Do you want to share what you your summary of what you heard from the group on related to that question?
Yeah, so I mean, pretty much it's what we do, you know, as peer support, we don't cut people off, so to speak, right? I definitely do refer her out for other needs, but continue to be there to support her while she's, you know, going through that process. And definitely, you know, helping her like make those calls and talk to those, you know, talk to the other referrals is always helpful.
Yeah, that matches what I was hearing as well with the comments. And then the discussion around feeling discouraged and whether you should share it or whether that's unethical. Do you want to share what you heard about that, or if there's any questions specifically about that?
Yeah, I mean, so again, it's like, and you know, that's kind of pretty much what we do, is that it's part of being a peer is letting them know that, you know, hey, I'm not sure what to do and I am stuck, and let's sit down and figure this out together. And just I'm not discouraging her, but also kind of letting her know how I'm feeling. And it actually has more than once, you know, it's a two-way street, right? So she's given me advice on things, which kind of can help the situation. She's like, well, I'm like, well, I'm discouraged. And she'll say, well, how about we try this? And then it kind of, you know, solidifies that bond.
Great. And then, you know, we tried to help tackle with you some very specifics around legal aid and around resources, although it sounds like, unfortunately, or, you know, fortunately, I mean, you've already kind of tried or crossed those bridges, which I think is just further evidence of your own expertise and efficacy in this space. But I hopefully with you heard from the group, and it reinforces that those are the services out there that we think could be helpful. Any other last questions or comments?
I just wanted to kind of echo what Phil said earlier, this lady has been a victim of so many awful circumstances, but throughout all of this, she's remained empowered, able to escape a terrible relationship and stop using substances and take care of her daughter really well throughout all this. And so I'm kind of struck by that. And, you know, we may be feeling like we're reaching like a stopping point in how we can help her. But I mean, realistically, that we are experiencing a lot of barriers, but she has a good trajectory to go, and just in terms of her, I hate to use this word, but in terms of her resilience. And I applaud you, Lindsay, on that, and I applaud her, even though she's not here.
Thank you.
Thank you, Jan. Well, wonderful, you all. Thank you for, like I said, spending your lunch hour with us. We reviewed the New England Journal article from the summer with Honora Englander about policies that will help advance the care of substance use disorder in hospitals. And so wanted to review that as a group of committed individuals wanting to lead together in this space so that we understand the policies we can be advocating for, and those that fall much more within our own realm of influence. So particularly local policies that we might be able to apply. And I think also a, in some ways, master class in the power of framing the argument and you know, bringing these analogies to bear. And then an excellent discussion and reflection on a really challenging case. So Lindsay, thank you for bringing that forward as we think about how we can best support our patients, not just medically with the effective medications for substance use, but also all of the support and incredible work that you all do to support our patients moving forward. So thank you all, and we look forward to seeing you at the next ECHO.
Thank you so much for joining us. Have a good one, everyone.